Today, today is a special VMR, and we are all together, and we're so excited to see you today. So today's format is we are going to have two cases. That's amazing too. And already Hime has a case, so we just need one more case. I don't know if Kushal already has it, but every case are welcome. And just to introduce myself, my name is Kiara. I'm from Peru, and yeah, that's all for me. So hi, Hime.
Hi, I'm presenting a case today. For you who don't know me, soy María Jimena, soy de Guatemala. Recientemente terminé medicina y pues les tengo un caso que vi hace poquito. I don't know who wants to go next, maybe Rafa.
Just a hypothesis, but when we switch languages, can you see how much the intonation of the voice changes? Maria speaking Spanish is just, it seems like another personality. So yeah, my name is Rafael and I'm a last year medical student here from Brazil. Really glad to be with you guys here. Também vou falar um pouquinho em português. Meu nome é Rafael, eu sou aluno aqui da Universidade Estadual de Maringá, aqui do Brasil. A gente vai tentar buscar um pouquinho dos aspectos do Global VMR que a gente sempre tenta fazer, falar um pouquinho de língua, de cultura, e um dia muito especial para todos nós. So, how about you, Kitan? Can you tell us a little bit about yourself?
Kirtan's like, no, my identity is super secret. Is he there, Kirtan?
No, actually, the Rafa spoke too quickly. I couldn't even understand what he said in the last part. But then everyone was staring at me, so I thought, okay, it must be my part. Yes. So good morning, everyone. Myself, Kirtan Patolia. I am the final year medical student from India, and today we have Global VMR, two fantastic cases. So I'm looking forward to it. Let's see how it goes. And now I will pass mic to Sukriti.
Hi friends, माझा नाव Sukriti, which is my name is Sukriti in Marathi, and it's the language that's spoken predominantly in Maharashtra. I lived in Bombay for a while, which is the financial capital of India, so a little bit of culture. And with that, I'll pass the mic on to Ravi.
I'm going to catch the mic and decorate it in some Brazilian for you and pass it to Gabby before I steal it back again. Gabby, hello, good morning or good afternoon. Let me guess. It's 1:10 p.m. Brasilia time. Oh my God. I'm learning slowly but surely. Say hello, tell us how your day's going, and then we'll jump right into the case.
Hi, everyone. Thank you, Ravi. I'm Gabby. I'm from Brazil. I finished my residency in neurology a few months ago. And I'm very excited to be here as well. Estou muito feliz de estar aqui. Eu sou neurologista, trabalho aqui no Brasil e fico muito feliz de estar aqui com vocês hoje. Já estou muito curiosa para o caso que vocês vão apresentar. And now back to Rabi.
Ahla wa sahla, which means hello in Arabic. Mera naam Rabi hai, which means my name is Rabi or Ravi in Urdu. It's a delight to be here. Today we're going to mix things up a little bit. Rapid fire VMR was an absolute delight, but I think 3 cases was a little bit of a stretch. So we're going to aim for 2, starting with our dear friend Maria to presenting the first, and then Kushal, if he can, to present a second. As always, please contribute in the chat and be ready to jump on in and discuss the case with us live. Just as a reminder, we discussed a case a month and a half ago that was released on the podcast just this past Thursday. So if you haven't had a chance to check it out, you totally should. It made my heart melt just listen to all those wonderful voices in synergy together. All right, without further ado, let's jump into the case.
So I really hope you guys like it. This is a 60-year-old female who, I'm going to start the story on hospital day 10. She presents with increased somnolence. She was initially hospitalized for an episode of ketoacidosis triggered by a UTI. I'm gonna give some time for Curtin. That was appropriately treated. During the hospitalization, she was also diagnosed with CKD, and she persisted with like elevated creatinine levels and small kidneys on an ultrasound. On day 7, she spiked a fever, started having like a dry cough, leukocytosis, and was diagnosed with a hospital-acquired pneumonia. She was put on broad spectrum antibiotics, and 2 days later, she started having increased somnolence. She was only aroused by loud voice commands, wouldn't answer even simple questions, and couldn't name objects around her. She also couldn't raise her legs and arms against gravity. So, yeah.
Oy, oy, oy. Maria, can you summarize the PR in Spanish? Like what is the problem that we're dealing with in Spanish?
Sí, por supuesto, pues tenemos una paciente femenina de 60 años en su día número 10 de hospitalización, ingresó por una cetoacidosis, también fue diagnosticada con una enfermedad renal crónica y una neumonía asociada a servicios de salud y se presenta con somnolencia y alteración del estado de conciencia.
Awesome. Francisco, tell us what you're thinking.
Well, I was just specifying it is not a CAP because the patient has been hospitalized. So maybe the most common cause of pneumonia in these patients with somnolence and DKA might be an aspiration or aspirative pneumonia. I don't know how to say it.
Aspiration pneumonia. Yeah, you nailed it. How do you say it in Portuguese?
I'm from Peru.
Oh, you're from Peru. I'm so sorry. How do you say it in Spanish?
Neumonía por aspiración.
What's the second word?
Neumonía por aspiración.
Por aspiración. Amazing. Yeah, no, I completely agree with you. I think it's very unusual for this to happen, especially in a non-intubated patient. So I think we definitely have to think not CAP. Tiago was teaching us about something about how the kidney size is in diabetes. Tiago, do you mind making that point out loud?
Okay, so yeah, it calls my attention that the kidneys are small because for diabetes, when you have chronic kidney disease, the kidneys are normal in size, or even they are higher, not higher, taller. I don't know how to say it, but they are bigger, and bigger kidneys in chronic kidney disease, you should think about diabetes and amyloidosis. So that's what I put there.
I love it. I think that's a very, very helpful framework for what causes kidneys to fail, but to fail in an enlarging manner. I love it. Kiara, what are you thinking about medications here?
Oh, so if if I forget about her hospitalizations and I hear that there's a patient with insomnia, first I have to think about if she's taking any sedatives or opiates, or maybe if she has depression, there is an increase in insomnia, right? Or there is also hypothyroidism in elderlies that can be a cause of insomnia too. So just if I forget about her prior hospitalizations.
Yeah, I love it. I think that's such an important point, and we have to keep that on the back of our minds for sure. I think it's a very hard problem to solve. And when Maria started to say, "Oh, this is a hospital day 10," I was like, "Ooh, this is gonna be tough." It's gonna be tough because it's amazing how complicated things can get when somebody's in the hospital and they develop another complication. And it's primarily because you have to solve the problem with so many parallel hypotheses at the same time. You have to keep an open mind that your initial diagnosis was wrong and your patient has a syndrome that is as a result of their life even before they came in the hospital, or something that we did in the hospital caused this problem. So you have to think about those in parallel. And here we have to say, is this a neurological disorder that is somehow related to a prior presentation of DKA, CKD, etc., or this is a neurological presentation that results from the things that happened in the hospital, a misdiagnosis of pneumonia, maybe a complication of antibiotics, so on and so forth, or is this a thing that happened because of those two together? Is it because of her prior syndrome plus what we did? So it's actually a lot of things to keep track of. And this goes to show you why it's important not to put treatment in the mix until you know for sure. As soon as you pour an antibiotic, as soon as you do something, if somebody gets worse later, you have a much harder job to do. And I think the hard part now is our hypotheses are very loose and very wide because we don't know what problem we're trying to solve yet. We know the patient's confused and altered, and we know that her arms or legs cannot move against gravity. But the question is there weakness in the arms or legs? Or is it because she has an encephalopathy that she cannot respond to commands? But the worst case scenario is she is both altered and paralyzed, which has a very concerning combination of things, but she may just be altered and volitionally unable to move her arms. And I think that changes the neurological localization dramatically. So in this patient, I think we have to get an exam to understand, first try to localize the lesion and then generate hypotheses. But here I'd be worried that it might be something that we did in the hospital because of the occurrence of it in the middle of the hospitalization. All right, Mia, back to you for some more.
Great. I love the discussion. And yeah, it was a complicated case. So the past medical history was remarkable for long-standing uncontrolled diabetes, hypertension, the recently diagnosed CKD. She also had peripheral neuropathy and a previous MI 5 years ago. I saw in the chat that it's not usually like common to see ketoacidosis at this age. In Guatemala, we actually see a lot of ketoacidosis, even in type 2 diabetes, just because there's really very limited access to care. So people have like long-standing diabetes and they get all the complications. For the med, she was on insulin. She was also in metformin, which was discontinued during the hospitalization. She also had gabapentin, enalapril, aspirin, and atorvastatin. She had received Socin for her UTI and was on cefepime bank for her hospital-acquired pneumonia. For the physical exam, she was febrile. Vital signs were normal. She had rales on both long bases bilaterally. Cardiovascularly, it was normal, rate and rhythm, no extra sounds. For GI, soft, non-distended, non-tender, no visceromegaly. For the neuro, she was stuporous. She was only oriented to person. Her pupils were isochoric and reactive to light. Cranial nerves were intact. Gag reflex was intact. She was aphasic, and we couldn't really assess motor strength because we didn't know if she did have like true weakness or she was just unable to move them, and her reflexes were normal. I'm just gonna give some time for her labs. She had leukocytosis. It started in like 22,000, and then like on day 10 was 18,000. She had the creatinine at day 1 was 4.5. On day 7, it was 2.7, and on day 10, it was 2.5. Her BMP was normal. She had an albumin of 3, but otherwise unremarkable. She had a COVID test that was negative, and then she had a lot of neuroimaging done. So CT non-contrast was unremarkable. The MRI was unremarkable. An LP was performed, and it was unremarkable. An EKG was also unremarkable, and an EEG showed non-convulsive status epilepticus. And that's the end of the second aliquot.
Oy, oy, oy. All right, my friends. Gabby, can I ask you to help us with your neuro hat on and kind of teach us how you would localize the lesion based on the exam that you have?
I don't know if I can help, but as far as I understand, there is no focal signs in the exam, right? Actually, I would localize. How do I say in English? I mean, there's something that is called the reticular and what is the name? Oh, does anyone know Sarah in English? The system that is responsible for maintaining the person awake. Yeah, reticular activating system. Yeah, thank you. So there is something that is, I think it's probably it's an encephalopathy causing this system not to work so well, and that is causing her to be somnolent. But from the exam, I cannot understand any focal lesion as far as I understand. I may be wrong. And the non-convulsive status epilepticus, also she is not having convulsions that we can see, for example, only in one side of the body. So this also doesn't help us in localize in a specific brain part, but I'm not sure.
I'm right there with you, my friend. I think the seizure findings are very localizing, but it's very hard to say where the problem is, and it might be because the problem is in many places. I think that's the challenge with neurology is we try to localize the lesion in one place, but often it may be that there are many places where there is disease. Kano, tell us more what you're thinking about the nuchal rigidity. I don't know if Kanu has the ability to unmute himself. In the meantime, Kiara.
Hello.
Oh, there he is. There he is. Go ahead.
Yeah, I'm sorry.
No worries at all.
So yeah, I was just wondering because of the increased leukocytosis there, whether it could be like encephalitis or meningitis. I just wanted to detect for any signs of meningitis that included like nuchal rigidity or Kernigh's or Brzezinski's, where the meninges become like very irritated and it's very difficult for the patient to flex their neck. So I was just wondering whether it's because the LP is also normal. So I was wondering whether those physical signs could help us move in some direction.
Yeah, I think it's a great analysis. At the end of the day, you often can you get meningitis with a normal LP? The answer is yeah. There are some forms of meningoencephalitis that the LP is normal, but the harder question is, do you do an LP in somebody without neck rigidity? And I'd say it's hard. It's a very hard thing to study. I would say my advice to everybody is an LP is an incredibly safe procedure. So if you are thinking about an LP for more than 1 minute, you should probably just do it. The morbidity of an untreated diagnosis that an LP could catch is so high that if you're really thinking about it, you should just do it. I've yet to see in my career anybody have a complication for more than 2 days from an LP. I've yet to see it. So it's a very safe procedure. It might be safer than getting an arterial line in the patient, quite honestly, which we do without any qualms when they're sick in the intensive care unit. So Kriti, what are you thinking about the creatinine?
I was just wondering if the improvement in the creatinine is a clue. I was thinking of Clostridium difficile diarrhea and how sometimes the improvement of the diarrhea is actually a sign of worsening of the situation leading to toxic megacolon. So, analogous to that, I was thinking if maybe this is a clue to something in this patient's diagnosis.
Brilliant. I think it's so easy to celebrate things that are improving, but sometimes when things are improving, maybe heralding something sinister. My favorite recent experience is a patient who had type 1 diabetes started to abruptly have much more better glycemic control, and she turned out to have adrenal insufficiency. And I think here, there are many ways sometimes better is actually not better. And I love that you're studying that possibility here. Let me, because we have only a few minutes for this case before we transition to Kushal's. So On the most recent podcast episode, I won't tell you it in case you're listening to it, but it was a case of somebody who got much worse in the hospital. And whenever somebody's worse in the hospital and they've received antibiotics, you always want to wonder, is this a complication of antibiotics? And that is something that we always have in the back of our mind. But that's the background. What's the foreground here? The foreground here is to think about this question. How can someone have a brain disease with a normal MRI? Think about that. How can someone have a brain problem with a normal MRI? This goes back to the very first clinical problem solvers episode of altered mental status. And if you think about the schema we shared there, MIST, M-I-S-T, M for metabolic, I for infection, S for structural, and T for toxin. M, I, and T are things that are outside the brain that cause a brain problem. So if you are in a world where you are so worried about a brain problem inherently that you got an MRI, it's helpful to have a schema for what is an MRI negative brain issue. And that ultimately comes down to recognizing that there are a lot of extrinsic issues in the brain that can cause encephalopathy would not show up on MRI. For example, hyponatremia, right? But what are things that are in the brain that don't show up? And I think that list is pretty short. It's autoimmune encephalitis, some kinds of vascular diseases, psychiatric diseases, and seizure. Now, some seizure actually will show up on MRI. Some seizure, you'll actually have findings in the cortex, diffusion restriction in the cortex suggestive of a seizure. But if you're saying MRI, after a basic evaluation, MRI negative brain disease, autoimmune encephalitis, vasculitis, psych, and seizure. And here we found seizure. What's our approach to seizure? The approach to the cause of seizure is the same as the approach to cause for altered mental status. Let me share that with you. Bye. So take a look at this. Oh, sorry, I shared the wrong one. Here you go. So your job with seizure is to first prioritize treatment over diagnosis. You want to get your ABCs right. You want to make sure you're never missing hypoglycemia and prepare your benzos. I share the advice that you should record the seizure activity to share it with your consultants, but that's controversial because it's taking patient information and putting it on your phone. Don't quote me on that, although this is recorded and now going on YouTube. Great job. Okay, and then you're going to do your thing and treat the seizure, but we're a DX focused podcast. We don't really prioritize treatment, so I'm going to skip over this part and tell you that the approach is M-I-S-T, missed mnemonic, and add a G. What's the G for? The G is for genetic causes that are negative after you do your M-I-S-T. Maria has done a great job. The LP is normal. I could be in pneumonia, but that seems to be unusual causes, and the MRI is negative. T, toxin. G, genetic, probably not happening here. And what's the toxin here? Toxin, the chat is already on it. The chat is very, very concerned about a specific toxin, and I think Kushal mentioned it. So why don't we have Kushal tell us what he thinks about the toxin involved here, which I hope we're on the right track, given Maria's little nod and smile, but there we go. Nice poker face here.
Yeah, I was thinking about cefepime because it classically causes seizure, especially if patient has impaired renal function. And I was checking whether it's imbalance of humors that's causing it too.
I absolutely love it, my dear friend. That's awesome. The imbalance of humors. Maria, teach us, please.
Yeah, you got it. So in this case, after doing all of the workup, the cefepime was removed from the list of medications from the patient, and like an act of magic, 2 days later, she was completely normal in her basal normal mental status. She even, I remember it was a Friday and I left the hospital, and when I came back on Monday, I was really worried for the patient. She was the first patient I saw, and then she was like, why is my hair all messy. Like why did this happen? I'm like, she's talking normally and she's complaining about her hair. Like what happened? And yeah, she improved significantly over the past 2 days. So yes, it was cefepime-induced encephalopathy. And as Kushal said, I'm gonna send a link of one of Aaron's articles he sent me when I told him about this case. And then there's basically a lot of medication-induced encephalopathies, and then antibiotics is one that we definitely have to worry for, especially in the context of this patient who had renal failure. And then there's basically 3 types of antibiotic-induced encephalopathy. It's the type 1, that it's more seizures than psychosis. That is very common about like penicillins and cefepime. And then there's like type 2, that is more psychosis than seizures. And that is usually caused by quinolones and macrolides. And then there's a really tardive mix of both, which is caused by metronidazole. And yeah, so that's the takeaway point for me. Always check the meds, and especially in chronic kidney disease patients. And it's like standard in my hospital to use cefepime even in chronic kidney disease patients. And it's the first time I've seen this, but I'll definitely remember it forever.
What an absolutely fantastic case, Maria. Thank you so much for presenting it. I think it really is a humbling reminder that sometimes as we try to do well for patients, we end up hurting them, and that's part of the price we pay. Medications. I heard this. What was the quote? I'm trying to get it again. It's like drugs are poisons that work well only within a specific dose. Like essentially, like you're putting something foreign in somebody's body, and you're trying to do the bare minimum you need to make them feel better. But sometimes you get unlucky, and some people react abnormally, or some people are predisposed because of kidney disease, so on and so forth. So yeah, a wonderful case. Thank you for all the learning. I'm curious if you could summarize 2 of the biggest teaching points that you took away from it in Spanish.
Sí, por supuesto. Entonces, el primero les diría es revisar los medicamentos, en especial en el contexto de una paciente con enfermedad renal crónica. Siempre, siempre, siempre. Y el segundo es de los tipos de encefalopatía inducida por antibióticos. Entonces, el primero, piensen convulsiones o mioclonía, más que psicosis, y pensar en penicilinas y cefepime. El segundo, pensar más en psicosis que convulsiones, y se caracteriza los medicamentos como quinolonas o macrólidos. Y el tercero es tardío, la presentación es semanas después de haberlo usado, y es como una mezcla entre tener convulsiones y psicosis, y ese es el de metronidazol.
I understood so little, but I absolutely loved it. Thank you so much. Maybe we can transition to the second case with Kushal jumping in to present. I just need 30 seconds to go close a window in the other room because it's so cold over here. I'll be right back. Sorry. All right, let's rock and roll. The last time Kushal presented a case, I was so nervous, so I'm feeling it again. All right, Kushal, I'm going to guess already. TB, syphilis, mucor, aspergillus.
Something like that. Something like that for sure.
How's your
So
daughter?
this is
Is she with you right now?
Sorry?
Is your daughter with you right now?
Yeah, she's playing around. She's running around the room.
Wait, how old is she now?
She's 19 months.
Oh, and how's it going? Is it the terrible twos yet, or how?
And she is very playful. She has her phases where she wants to do the things she wants to do.
Aw.
and she wouldn't have it other way.
That's
But right now she's behaving.
good,
Not
good.
well.
The wonderful dad in you. We all know that. All right, teach us, my friend.
Yeah, so this is a case of a 40-year-old male, comes with a history of urinary retention since last 3 weeks. Uh, so before the urinary retention started, he has been having urinary frequency, nocturia, and difficulty initiating urinary streams since last like around 2 months. Uh, uh, 5-6 months ago, you can hear her in the background. 5-6 months, she's trying to talk. 5-6 months ago, he was diagnosed with pneumonia, and he had like around 3 ER visits. He got different courses of antibiotics with some improvement. Since around 5-6 months, he has been feeling generalized weakness, and he has noticed around weight loss of around 18 pounds in last 6 months. And so since last month, he had 2 ER visits for retention. They did in and out cath, and he felt some improvement, returned to ER couple days later with the same symptoms. So he was placed indwelling Foley catheter and referred to urology. And he was discharged on levofloxacin, tamsulosin, and pyridium. When they did the UA in the ER, they found 13 to 20 WBC, 3 to 5 RBC, and 1+ bacteria, but urine culture was negative. And one other thing, also within last month, he was treated by his primary care doctor for cutaneous Staph aureus infection with mupirocin and Bactrim.
Wow. All right. Okay. Y'all, very intriguing. Very, very intriguing. I think our minds are probably going different places, but I'm going to ask us to practice something that we probably don't get to practice much, which is let's try to come up with a systematic way of approaching urinary retention. So I'll mute myself for 15-20 seconds and just try to come up with the diagnoses that cause urinary retention or a way to think about it, and we'll reconvene in a moment. All right, Kano, kick us off. How are you thinking about it?
Yeah, so whenever I think of like the urinary retention, the first thing that like comes to me is like the bladder outlet obstruction, because I think that's the most common cause. But even like the urinary retention, if you think about it anatomically, it can be from the bladder to the urethra, which has like 4 different parts. And there's the prostatic urethra, which is the first initial part, which is surrounded by prostate. So the BPH is one of the most common causes that causes a retention. And anything that's blocking the urethra, whether it could be a stricture, whether it's a stone, whether it's like a tumor, it could be anything like that. That could also cause it. And apart from that, not just like the anatomical causes, but something that's innervating the bladder itself or the muscles, like the detrusor muscle. If there's something wrong with that, that could also cause it. And in females, I think one of the other causes is like pelvic floor weakness,
Yes.
or pelvic organ prolapse that could also cause it. But since that's not the case here,
Yep.
I like to think of that way, especially in this like young male. BPH is low down on my list, and I'm thinking more of the other causes. And then the drugs also in the chat, like they mentioned, the anticholinergics, the opiates, drugs like that are also like very prone to cause urinary retention. The last time I had a case of that, it was opioid-induced urinary retention. So that is certainly something on my mind.
For sure. I love it. That's absolutely brilliant, my friend. And Valeria has mentioned the autonomic dimension of it. Valeria, do you want to just expand on that a little bit?
Sure. I was just referring to maybe the patient had some compromise of her autonomic system, like the patient had diabetes, for example. Maybe that could explain also the fact that she has some weight loss. But I think the fact that there's increased frequency, I wouldn't instantly in a male patient associated with diabetes. I will more likely see something in the prostate, maybe that's compressing the bladder.
I couldn't agree more with you. I think that if we were to apply the combination of yours and Kanu's approach, you're like, urinary retention can be because the muscle is weak or because there's something blocking the muscle from working. And the truth is that autonomic dysfunction of the bowel and bladder is usually occurs in the context of weakness elsewhere. It's very unusual just to have autonomic disease of the bowel and bladder absent any other signs of neuropathy, which is a very helpful way of prioritizing between the obstruction list and the neurological list. The problem is that the neurological risk is way more morbid than the obstruction list. And so we have to think about that. But the fact that he can still ambulate makes it a little bit less, or that he doesn't have any sensory symptoms in his lower extremities, makes it very unusual that he might have a neurological issue. So if I were to take all your thoughts and put them visually here, um, we're saying that it's one of either obstruction or neurogenic, and the fact that he can still have he has no other neurological signs makes us fall a little bit here. And Kano said, it's unusual for BPH to present so young, and the two exceptions to BPH presenting young are patients who inject anabolic steroids or a testosterone. They can have an enlarged prostate at a younger age. And I've also seen a case report of acromegaly resulting in a big prostate. But remember, other things can block: strictures, stones, clots. When there's pain in the penis from HSV, for example, you can also have a difficulty. And then most importantly, I think we have to think about this. Why do we have to think about a mass in the prostate like an abscess? It's because the patient has had multiple foci of infection elsewhere. And those foci of infection have been in the skin and the lungs. And of course, because Kushal is presenting, we have to prioritize anything infectious disease. And so I think going into this, we have to take a better picture of this, either through a CT of the pelvis, an MRI of the pelvis, or urology to deploy one of their more advanced diagnostic tests. But I think the key question is something obstructed very acutely. And because he has infections elsewhere, do we have to worry about an abscess? And the list of causes of prostatic abscesses are extensive, ranges from anything that is local flora, namely the gram-negative rods, to esoteric granulomatous diseases that have a propensity for the prostate, including one of Kushal's favorites, melioidosis, which if it shows up here in the United States, I wouldn't be surprised, but I would be learning for me. All right, Kushal, back to you.
Okay, so patient is not taking any medications, no previous past medical history. In social history, he lives in Kentucky. He likes hunting and camping, and he is not a smoker, no alcohol use, no IV drug use, or any illicit drug use otherwise. And physical exam, let me show you the skin rash test on the left knee and left arm. Can I share my screen?
Go for it. Wow. Okay. That's very impressive, my friend. All right, y'all.
Okay,
Yeah,
and And the other significant physical exam finding was when they did the rectal exam, they noted that patient had moderately enlarged multinodular fixed prostate gland. So they were worried about locally progressive prostate cancer. Labs showed normal CMP, CBC. The only significant lab was the UA, which showed again 13 to 20 WBC, 3 to 5 RBC, and 1 plus bacteria. And urine culture was negative.
Uh-oh. All right. I'm going to let folks think for a second and then see what everyone's thinking. Oh, Gabrielle, you had some thoughts too. Tell us more.
Yeah, Ravi, I agree with you about you said granulomatous diseases that can predispose to prostatitis. Some differentials I was thinking first was some kind of fungi, like for example, blastococcidio, and TB, of course. And yeah, and I say that because linking with that weight loss, trying to prioritize first some time of infection and malignancy.
Beautiful. I come right there with you. Hans is asking for a prostate biopsy. Hans, can you tell us more?
Yes, if we can't tell whether it's an infection, an abscess, or whether it's a malignancy, we might need a biopsy. And I think it's always done before we start treating the prostate cancer.
100%. I completely agree with you. In many, many instances here, tissue is the issue for sure. Travis, what are you thinking here?
You able to hear me?
Yes.
Okay, I'm driving, so it might break up. You know, the first thing I was thinking of the weight loss, I think I'm leaning towards it being something either mycobacterial or some other fungal disease, given the systemic symptoms and the cutaneous findings. So that's where I'm leaning right now.
Beautiful. I absolutely love it. Anne-Marie, you're teaching us so much in the chat. I love your posts along the way. Where are you at right now?
I just, since it's a Cushall case, I just had to mention melioidosis. So I was just joking that if this were a male in Australia, that would be the top of my differential, as you mentioned, since it's very common cause of prostatic abscess there.
Yeah. 100%. Mohammed, hello, congratulations on graduating. Please say hi and tell us what you're thinking.
Hey Robbie, thank you. How are you guys? It's been a while since I came here. I miss you guys too. I've been busy at work with the electives and sub-Is and stuff, so I haven't been coming as much anymore. But I miss this so much. Yeah, I was thinking it's something more of chronic since first I heard about the weight loss, and I don't know if sarcoidosis could cause skin finding like these. I don't know. I'm recently I've been thinking a lot about sarcoidosis in general. I'll try to keep it at the back of my differential, but maybe something like sarcoidosis or another chronic inflammatory disease causing the weight loss, and then the pneumonia and the prostatitis or the enlarged prostate.
100%. I think I'm right there with you all, and I think that one of our earlier episodes actually was a case from Chris Jackson. I think it was episode 20 or something, a long time ago. There was a tension between sarcoid and granulomatous infection, and that's a tension that I think will constantly exist. I think here you have to prioritize infections before you think about sarcoidosis, and I don't think it's impossible that it ends up on sarcoid for sure. And the question is, well, how can we make progress on what kind of infection? We're already worried about granulomatous infections, and we have some clues. The clues are twofold, that that there's lung involvement and skin involvement potentially with what Kushal told us. But I would argue that there's another really important clue, which is that this is an otherwise immunocompetent appearing man. And if we're thinking about all the things that can disseminate in an immunocompetent patient to lung, skin, and prostate, if you were to say of the mycobacterial diseases, what disseminates, it would be unusual for a non-tuberculous mycobacteria to disseminate, though MTB is certainly on the list, as is M. bovis. Within the endemic mycoses, it would be unusual for crypto to disseminate in an immunocompetent patient, though that's described. And then histococci, all are more likely to disseminate in immunocompromised patients. So I think of the endemic mycoses that's most likely to result in disseminated disease in an immunocompetent patient, it's blasto. And if you're trying to do an arms race between blasto and TB, in Kentucky, blasto is much, much, much more common. So I think it's important that we focus on endemic mycoses. And if you marry the geography with the fact that this is a skin, lung, and prostate syndrome, I think blasto is probably the most probable. But before we pass the mic to Kushal, I think what we're worried about is the granulomatous process, followed by sarcoid. And as Hans reminded us, don't forget about malignancy. But before we pass the mic to Hans, Rafa, do you want to summarize the problem representation in Portuguese before we get more data?
Can I just say that this time, Rabbi let me know earlier that this was coming. Usually it's by surprise. Então, nós temos um paciente de 50 anos, masculino, que tem uma história de retenção urinária, que se apresentou com noctúria, aumento da frequência. Ele também estava com dificuldade no início do jato urinário 2 meses. Também foi diagnosticado 5, 6 meses atrás com pneumonia, foi tratado com múltiplos antibióticos, teve alguma melhora, também reportou fraqueza, perda de peso, continuou com a retenção urinária, acabou sendo diagnosticado com pneumonia, que eu esqueci como que é em português, e também com infecção cutânea por Staph aureus. So that's basically it.
Wonderful. Amazing. And I see Kanu has summarized as a 50-year-old man in Kentucky with 2 months of lower urinary tract symptoms, weight loss. Yeah, we only have a few minutes left, so maybe I'll pass the mic to Kushal to take us home, and then we'll conclude.
Hi, so you want me to go up all the way to the end to the diagnosis?
If you don't mind.
Sure, I don't mind. Okay, let me share the screen again. So this is the CT scan. It showed hypoattenuated prostate, and they were suspecting either prostate abscess or malignancy. So after that, they did the TURP, and they found a lot of chocolate-colored purulent discharge, and they sent the routine fungal and AFP cultures. And these are the biopsy results. This is more obvious.
Anyone have a guess before Kushal tells us? Broad-based budding. Emery, tell us more, please.
Oh, just the broad-based budding yeast is consistent with a diagnosis of blasto. And this case was also a blasto.
There we go. This case is also a blasto. What a name, too. Like, whoever named this blastomycosis? Maybe Kushal knows, but yes, Kushal, teach us, please.
Yeah, you guys got it like almost from the second undergrad. So I'm so glad that my camera's off. I couldn't keep my poker face on.
Maria had a hard time too, my friend. It's not just you.
So yeah, you guys were on the right track. Basically, you suspect something like blasto, where patient was diagnosed with pneumonia, where the history is not quite convincing, And blasto can present with cap-like syndrome. We had a previous VMR case like that as well. And whenever we have skin lesions, especially when it looks like squamous cell carcinoma, we have lung possible cap-like syndrome in past. And whenever we have either bone lesions or GU tract involvement, like Anne-Marie mentioned that prostatic abscess is really common with blastomycosis. Or so those are the main things, and epidemiology definitely helps. Blasto is common in Mississippi, Ohio, river valleys, and also in Great Lakes area. Wisconsin is the state with highest amount of blastomycosis cases. So the main teaching point is the atypical presentation of blasto, where it can present like this with urinary retention. And I saw this case in the recent winter course infectious disease conference, and I really liked the teaching point, so I wanted to share. But I knew that now everyone in VMR is going to get this diagnosis, so and I wasn't surprised at all.
Absolutely fantastic case. Thank you so much for it. It's such an unusual. Most urinary retention ends with a Foley and a referral to urology, but sometimes it ends with blasto. Thank you so much for presenting it. You know, since we covered 2 cases today, I think it's probably good that we recap both of them. So, Maria, do you want to just summarize our first case, and we'll ask Gabby to teach us what we learned from that case, and then I'll ask Rafa to summarize this case and Gabby to teach us again before we say goodbye.
Perfect. Do you want me to do it like in Spanish or English?
In Spanish, please.
Sí, pues el primer caso, tuvimos una paciente femenina hospitalizada en su día número 10, tenía 60 años, ingresó inicialmente por cetoacidosis y luego fue diagnosticada con una enfermedad renal crónica y una neumonía asociada a servicios de salud. Después de iniciar antibióticos, inicia con somnolencia y a los exámenes todo salió negativo, excepto un estatus epiléptico no convulsivo en un electroencefalograma. El diagnóstico final fue una encefalopatía por cefepime.
Amazing. Gabby, what did we learn?
Yeah, I learned a lot with this case, actually with both cases. I really enjoyed them. I think in the first case, I really liked the mnemonic mist, which is metabolic infection, structural and toxin. And we have to think about metabolic infection and toxin if we have a brain problem and a normal MRI, which was the case in this patient. And other diseases are autoimmune encephalitis, seizures, and psychiatric diseases. I really liked the teaching points that Maria brought us about the type of antibiotics induced encephalopathy with the 3 main types, which are type 1, including seizure caused by penicillin, cefepime, and type 2, usually causing psychosis caused by quinolones and macrolides, and type 3, which is have a more late onset and causes seizure and psychosis, and it's related to metronidazole use. I think that's it from the first case.
Oh, good. Thank you. All right, Rafa, do you want to summarize the second case in Portuguese?
Sure, but first let me just translate for you just a short sentences that someone sent in the chat in Portuguese. So Natalia says that she loves Global VMR because she can practice her English, her Spanish, and clinical reasoning, and you are perfect. So, the second, I'm sorry, em português. Então, nesse segundo caso, foi apresentado pelo Cuxal, a gente teve um homem de 50 anos que se apresentou com retenção urinária aguda e também sintomas urinários há 2 meses, com noctúria, aumento da frequência e dificuldade de iniciar o jato urinário. Esse paciente também referia a perda de peso e também episódio de pneumonia prévia. E quando a gente examinou o paciente, a gente viu que ele tinha uma próstata aumentada e também lesões cutâneas. E uma das coisas que a gente tem que lembrar com lesões cutâneas, doenças disseminadas em pacientes imunocompetentes, são as endomicoses, particularmente a blastomycose, which was the final diagnosis, and that's it.
Wonderful. Gabby, what did we learn?
Yeah, I think the main points here, the clinical pros here, is that what Kushal said about when to suspect about blastomycosis, which was what Rafa said in Portuguese. But we have to think about blastomycosis in a patient with, the person can be immunocompetent with a previous pneumonia, with a skin lesion that can resemble a squamous cell carcinoma, which was the case here. The person can also have bone lesions and urinary tract symptoms. And it's also important to think about those diseases. We have to think about what is the geography involved, and blasto is more like common in the Great Lakes area. And I think that's it for the second case.
100%. We learned so much, and I really love this format, learning to be exposed to more and more languages, hang out with you all, and to nerd out with two fantastic cases that touch neurology, the lungs, the skin, the urinary tract, antibiotics, just all the fun. I hope to see you all around anytime during VMR in the week, and especially next Saturday. Bye.